examination. As we all know, eye examination in children cannot be done as methodological as in adults. It's an art. So, over the next few sessions, we are diving into the world of pediatric eye examination, a realm where your insight and skill will impact the life of young children. This IC will be covering the topics from the child entering your OPD till the posterior segment evaluation. I am Dr. Remya, pediatric ophthalmologist at Cooperative Hospital Pioneer, and I have with me eminent pediatric ophthalmologists from across Kerala. I will introduce one by one. Dr. Monisha Mohan, she is a pediatric ophthalmologist at Ahalya Eye Hospital, Palakkad, and she will be talking on tips and tricks in pediatric eye examination. Next, I will be covering vision assessment and refraction in kids. Dr. Lakshmi, she is Associate Professor at Malabar Medical College, Calicut, and Consultant Pediatric Ophthalmologist at Abate ASI Hospital, Calicut. Next, we have Dr. Soumya Nambiar. She is a Consultant Pediatric Ophthalmologist at Comtrust Eye Hospital. She will be talking on evaluating a child with strabismus. Next, we have Dr. Laila Madam. She is the HOD Pediatric Ophthalmology, Comtrust Eye Hospital. Ma'am will be covering importance of extraocular movements. And lastly, we have Dr. Neena Ma'am. She is the HOD at Giridhar Eye Institute, and she will be talking on relevance of posterior segment evaluation in children. Without further ado, I invite Dr. Monisha Mohan for her talk on tips and tricks in pediatric eye examination. Thank you.
Good morning, everyone. At the outset, I would like to thank KSOS Drishti and our Chief Instructor, Dr. Ramya, for including me in this IC. I'm so happy and grateful to be among such eminent panel here. So let's start. So my topic is tips and tricks in pediatric eye examination. So there are a few things that we need to know before we start pediatric eye examination. First is to maintain a fair distance from them. They do not like you getting very, very close to the kids. Don't expect the examination to go as orderly as you would expect it in the adults. You need to be more malleable, and you need to do the most important things first. So try to do the non-contact procedures in the beginning, because once they experience any discomfort in contact procedures, then that would mean that it's your end of your examination. You cannot do anything further. So when you allow the children in your OPD, allow them to move freely in the OPD, and when you want to examine them, then you make them sit on the examination chair. So till then you can grab some history while they're moving around. So how to strike a conversation? Usually the patient is always right. So in our case, the kids and the parents are usually right. Because the parents usually tend to overlook the mistakes in child, and if they're stating one, then definitely there is some issue in the child. Friendship is established in the waiting room. Try to make them that they are the most important people in the room. Try to make it kid-friendly and have a lot of toys and books in your waiting room. Provide them with a lot of stickers, cartoons, and toys to help them in their examination. Try to find out what their favorite cartoon is. Try to find out what they like to be called. Call them out frequently. So this will help them in a feeling of belonging and a familiarity with them. And with older children, while you're doing examination, you can always talk regarding hobbies. They often appreciate a handshake or a pat on the knee, and appreciate them often when they are obeying your orders. So if the child is too cranky, or you identify any child who is mentally disabled, you always examine them first yourself instead of getting them examined by an optometrist. During examination, flexibility is the name of the game. Like I discussed, it is important to be malleable. Don't expect it to be orderly. Explain them what you're doing. Show them the instrument, the equipment with what you're using. Try to be honest. Don't take them by surprise. Then they will not adhere to your orders anymore. Show it on the parents. If you want to instill drops, then you instill them in the parents. Tell that it would just sting. It will not hurt. So all this will go a long way during your further procedures. Even while doing pupillary examination, shine the torch on the parents and then do it on the child. If you want to apply a patch for the child, then you ask the parents themselves to do it. They'll be more comfortable like that. Smaller children, preferably to be examined on the mother's lap. Try to keep all your instruments, your attractive toys at your reach. You can't waste time searching for them. one look, one toy rule should be followed. You need to have a lot of toys which you can grab easily and show them, because they get bored easily and they become impatient also very quickly. So here are a few toys and the tools that you can use to grab attention at distance and near. Remember, face is better than the torch. Wearing bindis and spectacles grabs more attention. So here is a projectile flashlight torch that you can grab attention at distance. So it has a flashlight with a few sliders with multiple pictures. So this is how it looks. You can display multiple colorful pictures. All you need is a dim light, a little dim light than the usual examination room. For fixation stick, for near fixation, we commonly use the Lang fixation stick. So now kids are so smart, they just tell it in a jiffy. You would have hardly started your examination. So for such procedures, you can always ask them the details of the picture, like the car, the color, the number of wheels, the number of legs the elephant has, and so on and so forth. Try to avoid apron during your examination. Now for extraocular movements, I think finger puppets do a very, very good job. So here is a display of it. And the ease of fixing them at different fingers and flipping them while you're examining is very, very convenient with finger puppets. Now cell phones again can be used to show cartoons, but then make sure you tell the patient that you cannot use them at home to engage the child. Coming to anterior segment examination, we know that the ophthalmic unit chair is not same for the children and the other, it's the same for the children and the adults, so the height is an issue usually. So, but bottom line, you need to make sure that they're comfortable and they reach the height of the slit lamp. Now, for that, you can either make them stand on the footrest, you can make them kneel on the unit chair, or also add an additional seat on the unit chair. Try to see that they reach the height of the slit lamp, and you always have an assistant standing by. Now, since the COVID times, we have this protective shield that always comes with the slit lamp. Now, we can use this to our advantage by sticking stickers on either side. This is definitely better than using light or the torch, so you can always ask them to tell the details of the picture while examining them. A handheld or a portable slit lamp is a reasonable alternative, especially for children who are younger than 1 year or 1.5 years, and even for anxious and scared children if they are not cooperative on the normal slit lamp. However, information that we gather out of here is less detailed due to lesser resolution, and they're quite unstable in the hands. And also you need to go very close to the child while doing this, so most of the kids don't like it. So coming to posterior segment examination, best is to use your 20D lenses with the indirect ophthalmoscope. This is quick, and you can not only see the posterior segment, you can also see the anterior segment, the lids, the lashes, because of the magnified view. Now smaller babies can be held in this position where the arms are wrapped around the ear and above the head, and knees are held at the knee joint. Somehow children are very, very comfortable in this position, and they do not pose any kind of strain in any part of the body. So you can have something interesting up on the roof, like stars on the roof. So they can have a fixation there. You can always sing songs and make noises to keep them distracted. You can also do this while the child is sleeping. Sending the parents out, especially the mothers, in case you plan to put a speculum, is a good idea. And in older children, definitely with the 20D lens, we can get a very quick view. Now, being persistent is very, very important. Involving multiple strategies to get your pediatric examination right is very important. Not only that you get information out of the child, the parents themselves will find the effort from your side, and they appreciate it. Now, staying positive and having fun throughout the examination is important. So sometimes, even with everything at our disposal, some children just don't cooperate. So you need to ask them to come for a second examination, or you want to examine the child after 5 to 10 minutes or after a break, or you want to see another patient and see the patient back, can also be done, because it's very normal for us also to get frustrated during such examination. Now, never hesitate to do any examination under anesthesia or sedation. We can always take this as an opportunity to conduct other examination as well for a thorough workup. Thank you.
Thank you, Dr. Manisha. I think we will move on to the next talk by Dr. Ramya Edacheri. She will be speaking on vision assessment and refraction in kids. Is it really difficult?
Hello. Yeah, good morning, everyone. I know many of you are not pediatric ophthalmologists here. But any child can land up in your OPD. So you will be, that patient will be benefited by your guidance and appropriate referral is required. So my topic will be vision assessment and refraction in kids. Is it really difficult? I will be covering this under 4 headings: visual milestones, visual acuity estimation, and refraction in kids, and if time permits, a few practical examples as well. Coming to visual milestones, when a newborn child is born, the child blinks to light and the pupil reacts to light. And fixation to bright light and phases starts by 1 month of age. Fixation and following to accommodative target by 2 to 3 months. And the child recognizes mother's face by 4 to 5 months. Convergence, stereopsis, depth perception, color vision starts by about 6 months, and the rest of the visual developments are developed after that. So when a child is born, the visual acuity is around 6 by 240, which reaches to 6 by 6 adult level by 4 to 5 years of age. Coming to visual acuity estimation, there are an array of tests in children which recognition acuity, resolution acuity, and detection acuity. But I will be going to the most important ones which we do in our daily OPD. So I will be dividing into under 3 headings. That is pre-verbal children, 0 to 3 years. Verbal, that is pre-literate, that is 3 to 5 years. And verbal literate, more than 5 years. In pre-verbal children, we normally do resolution acuity. We do optokinetic nystagmus and force preferential looking tests and VEP. Whereas in verbal pre-literate children, you can do matching tests like HOTV and Lia symbols and K pictures. And verbal literate, as in adults, you can go for a Snellen chart or a Logmar chart. So this fixation and following, it should be done binocularly as well as monocularly. It's a qualitative assessment of vision assessment. So this is usually described under 3 headings: CSM, that is whether the fixation is central or not, and whether it is steady or not, if there are any nystagmoid movements, and if it is maintained. If you cover one eye and uncover, if the child is able to fixate the object properly, means continuously. So in this child, you can write it as central, steady, and maintained. Whereas, look at this girl. It's not playing. This one, first one. Look at this girl, even though the fixation is central, you can see there is nystagmoid movement, so it is not steady. Whereas the other child, the left eye is central, steady, and maintained. Whereas in the right eye, you can see when you cover the left eye and uncover, the right eye is not able to continuously fixate, so that is, it's not maintained. So according to the fixation pattern, you can have a rough estimation of the visual acuity. If the fixation is grossly eccentric, the vision is less than counting fingers. If there is unsteady central fixation, it's around less than 6 by 60. Steady, central, but it is not maintained, around 660 to 636. Central, steady, and maintained, but the child prefers the other eye, then around 624 to 612. And if there is a cross fixation and freely alternating, usually the child will be having a very good vision of about 6.9 to 6.6. This is how you roughly estimate. Coming to optokinetic drum, this is a drum with a dark and white stripes, and you will be rotating it. Then the child will be having a physiological nystagmus with a fast phase and a slow phase. So depending upon the gratings, reducing the grating, you can estimate the visual acuity. These are the tag cards. It consists of dark and white stripes on one side and a homogeneous gray area on the other side with a central peephole. So the examiner will be looking through the peephole and looking at the eye movements of the child. It is done at 38, 55 and 84 centimeters, and the visual acuity will be written on the back side of the card. This is how it's done. So the examiner will be flipping the card and looking at the movements of the eye. And if the child is able to do that, then we will take the next card and record the estimation. Similarly, you have the Lia paddles also. They will be flipping between the 2 hands and looking at the movements of the eye. It is written as cycles per degree. Then you have the Cardiff acuity cards. Here, what is known as vanishing optotypes will be there. So there will be a white white band which is covered with a bordered with a dark line. So all the pictures will be having same size, but the bandwidth will be decreasing. According to that, the narrowest bandwidth with which the child responds will be the visual acuity. And coming to visually evoked potential, it actually tests the integrity of the visual pathway. So only till the occipital cortex it measures. So if the child is having CVA and poor vision, but your VEP may be normal, so you should be careful in those cases. These are the methods of estimation at different age groups by different methods. And coming to the pre-literate children, here you have the matching cards. So these HOTV and LIA symbol cards, these symbols and letters have a vertical symmetry. That's why we use these cards. And here you just give the paper to the child, and the child has to just match with the chart given in the chart. Then another is response to occlusion. This is also a rough estimate. In this child, you can see the child is fixing with the right eye when I cover the left eye. But when I cover the right eye, the child is resisting occlusion. That means that the child has a very poor vision in the left eye. Coming to refraction in kids, speed is the essence of pediatric eye examination. So whenever you get a chance to do your retinoscopy, you should be able to do it. Then only when someone comes, you can do it very quickly. So cycloplegia is mandatory in kids. We use these drugs, atropine 1%, hometropine 2%, and cyclopentolate 1% in kids. You should make sure that inform the parents about the adverse drug reaction. And in case of squint, you have to occlude one eye, then do the refraction. Otherwise, you may get erroneous values. Especially in children with amblyopia, you may not be able to give the subjective correction depending upon your PMT. So your cyclorefraction values, you will be giving the prescription according to your cycloplegic value. Then these are the Bruckner's reflex. Here you can superior reflex if there is hyperopic, inferior reflex is myopic. Then these are the values according to the AOS and AAO guidelines. I will not be going to that. So myopia, hyperopia, and in a patient with a squint as well as in anisometropia. I'll just run through few practical examples. Here is a 4-year-old girl, uncorrected visual acuity 6/60, no squint, cyclorefraction is this much, but the child accepts only this much. So how much do you give? You have to give, for full value, you have to give minus 4.5 at 180 only. So don't give according to PMT. Here is a child with a 2-year-old boy, mother is myopic, no squint, cyclorefraction shows -1 diopter. But here don't give glasses, but inform the parents that the child is going to get the glasses in the future and explain about the measures to take to prevent the progression of myopia. Here last one, 1.5-year-old girl, inward deviation, 1 year, ET for distance and near, atropine plus 3.5. So here you have to give full correction because the child is having ET. But in a normal child, you may not have to give the glasses. So I would like to thank my teachers who were in my professional journey, Dr. T.K. Ramesh sir, Dr. Jyoti ma'am, and Dr. Chimay ma'am. Thank you so much.
Thank you, Dr. Ramya, for that exhaustive coverage. Now over to Dr. Lakshmi for treating lazy eye is not a lazy task.
So thank you, KSOS, and thank you, Dr. Ramya, for including me in this session. So I'll be covering the topic lazy eye. It's not a lazy task. The problem with amblyopia is that it is a long described problem, but it is just not a difference of lines or Snellen visual acuity lines of 2 lines or a crowding phenomenon. It is actually a problem with the visual experience that the child develops. So the child has reduced contrast sensitivity, poor reading skills, and ultimately the child turns out to be inappropriate for certain professions, so it becomes a public health problem. The types of amblyopia, we all know the different types. I am not going into the details. And the refractive error that could cause an amblyopia is different for different types. It could be 1 to 1.5 of anisohypermetropia, 2 diopters of anisoastigmatism, and 3 to 4 diopters of anisomyopia. And the guidelines we all know. The problematic cases are the hypermetropic or anisometropic hypermetropic children and strabismic amblyopic children where it's difficult. Occlusion, unfortunately or fortunately, remains the mainstay of treatment. So we come to the question of when to start, how much to start, whether to decrease or increase, should we add any other modality, and how do we deal with the recurrences and residuals. So amblyopia treatment guidelines has given us a lot of idea on how to go about this. It's a randomized controlled trial, so we have the guidelines and we start with a full cycloplegic correction as Ramya has already described. And we have to start with the optical correction, and how long do we wait after giving the optical correction. So studies have shown that it takes around 16 to 18 weeks for the optical correction to bring out its magic. But do we wait so long? The answer is most probably no. We usually start by 4 to 6 weeks after giving an optical correction to start occlusion. But in certain cases, like an older child, closer to 8 years, we might start off with patching along with the optical correction. So occlusion is more effective in along with the glasses according to some studies, but we might have to alter according to the patient. Now, how much to patch? What is the problem with the patching hours? We have umpteen number of studies like this, which shows that the compliance of patching is less than 50%. So that is the main issue, and we might need to counsel the parents time and again when they come for the importance of occlusion therapy. And how much to start with? It is 2 hours for a mild or moderate degree of amblyopia and 6 hours for severe amblyopia according to the ATS guidelines. This is effective, but do we step up the amblyopia treatment? Yes, because if we do not get a sufficient response even after 6 to 7 months or even 1 year of patching, we might consider increasing the time of patching. That might help in certain children. But the problem with this is we have to check the compliance, whether the child is doing the patching correctly and whether our cycloplegic refraction is correct. We might have to recheck that, and we need to rule out subtle ocular pathology which might be missed in the first sitting. Other types of treatments like atropine is effective. Studies have shown that it is equally effective as occlusion therapy, and in mild to moderate cases. Severe cases, it might not be an option. And atropine, we usually start with a weekend regimen or a twice weekly regimen. It's equally effective. How about combination treatments? Atropine and patching, usually it doesn't produce any added effect, but some cases it might be useful as an initial start off. In moderate amblyopia, you might start off with atropine and then shift to patching. Some cases it has found to be useful. And other drugs used, mainly a theoretical basis, we don't use it regularly. Now comes the innovations. Liquid crystal glasses have been used, but not much in vogue because it might be a little bit expensive and it's difficult for children to handle this. In this, the one eye gets intermittently occluded because of the changes in the liquid crystal. This is another one with the same type of mechanism. It's called an occlutab. The difference is the glass is occluded on one side and the child is able to do this task only with the glasses. You can see that the laptop or the tablet, you can't see the picture without the glass. And in this case, there are tasks like shaving the sheep's wool, and tasks like that can help the child keep engaged. Now, recurrence of amblyopia, we need to look into this matter when we stop occlusion therapy. Initial 3 months, we might need to follow up the child for a drop in vision where we need to reinstate the occlusion therapy or atropine. Treatment of older children, even though the child has been detected with an amblyopia, even at a later age, we need to give them a full trial of treatment, whether it be occlusion or atropine or any other form. Because even if they have crossed the amblyopigenic age, we need to give them that chance. So here comes the role of neuronal pathways in this. This concept is based on the retinocortical pathway, which is involved in amblyopic children. And it has been proven even previously that ocular dominance columns in the visual cortex are altered in amblyopia. The impulses from both the eyes will be different. And this results in an altered perception of vision in these children. So there are certain inhibitory and excitatory neurons which might be suppressed in amblyopia, and the modulation of these inhibitory and excitatory neurons can improve vision. So that is the basis of synaptic plasticity. That is a mechanism used by the brain to overcome brain damage. So these visual tasks have been employed in the recent techniques of perceptual learning and dichoptic stimulation. Perceptual learning improves these skills like vernier acuity, contrast sensitivity, and position sense, the direction of thing. So this is used in perceptual learning, and in dichoptic stimulation, they utilize the binocular stimulation more. So this is an example of perceptual learning, the Revital Vision, which is FDA approved. And these are the Gabor patches in which the orientation of the patches are changed along with the contrast sensitivity and the grating pattern. So the next is Binox, which utilizes dichoptic stimulation. These are simple games that can be utilized for treatment using goggles, which uses binocular stimulation. It's simple because it uses only the arrow keys for playing. So these are more effective with children because it might be interesting for them. The Dig Rush was a previously instated game, but that has not shown promising results, long-term results. So it's not widely or popularly used now. This is the Dig Rush game which was used before, the 3D goggles game. So points to ponder, we need to give the optical correction first, check for compliance and mode of patching, repeat cycloplegic refraction if needed, rule out subtle ocular pathology, may have to take a second look for that, and be cautious while tapering and stopping, and judiciously use the newer types of treatment. So that would be all for amblyopia. Thank you.
Thank you, Dr. Lakshmi, for that keeping the time and wonderfully covering that difficult topic of amblyopia, lazy eye. Now we move on to Dr. Soumya Nambiar. She is going to talk on the evaluating a child with strabismus.
So good morning all. First of all, I would like to thank KSOS and Dr. Ramya for having given me this opportunity. So strabismus per se is challenging in adults, and in children it is even more challenging. So whenever you have to see an object, to get a three-dimensional picture, the images of that object should fall on a disparate retinal points in the Panem's fusional area. Only then you will be seeing the object in a three-dimensional picture. But what will happen when there is a misalignment? These images do not fall on the disparate retinal points in the Panem's fusional area, and the child or an adult usually starts seeing double vision. But in children, what they do is that they start suppressing one eye, and then there is a loss of depth perception, and they may lose sight permanently. Okay? So strabismus is a common disorder of ocular alignment affecting about 2 to 4% of general population, and therefore early detection has a definite role in reducing the incidence of amblyopia. So today, let's see how do we evaluate a child with strabismus, though it's easily said but difficult to do definitely. So early recognition of strabismus is needed in order to prevent permanent functional issue, to prevent psychosocial distress in children, to prevent amblyopia, and you need to catch them during the critical period of development and also during the modifiable period of neuroplasticity. So always you can start your examination by observing the child as the child enters your room, outside your OPD room, as well as the child enters the room and goes on till the child is leaving. You can always observe when you keep asking history with the parents, and in the history you need to ask about under the following headings: how did they start, whether it was recent or it's there since birth, what is the frequency, the birth history, any perinatal, natal or postnatal issues, whether this strabismus or a misalignment started following an immunization, any family history, and if the child has taken treatment in the past. Always start your visual assessment, as Ramya has already told, with age-appropriate charts. And remember that you should always check the near vision as well, because that is the one which decides whether your amblyopia treatment is going to be effective, and that's the first one which improves. Then Ramya has already told about the CSM method. Okay, this is the most important method, especially in a child who is not going to cooperate. And she has already told in detail what is going to happen. So you can see the central steady fixation, and as in this child, you can see that there is a central unsteady fixation. And the important thing is that you have to look for the maintenance of fixation. So how do you check for that? She has already told. I'm just telling little more about it, is that by this you will know which eye is going to be dominant and which eye the child prefers to see. So you can see when I covered the left eye, the right eye is fixing, and it is maintaining fixation when I uncover. And when similarly, when the right eye is covered, the left eye from outward position has come to the central position, and when I remove the cover, the left eye, you can see it has gone back to its original position, which means that the child is preferring the right eye. Always look at the abnormal head posture, which decides upon which type of muscles that you have to look for when you are seeing. Whenever a child comes with an ocular instability in infancy, up to 3 months, if there is a less than 15 degree and up to 3 months, you can usually observe, but remember, rule out other causes. Do a dilated examination, do an anterior segment examination, then you can observe the child. But if there is an ocular deviation which is persisting for more than 3 months, if the deviation is more than 15 degree, it has to ring bells. There should be some problem that is going on. Pseudostrabismus is one very common condition which can be confused for a true strabismus. So this can be very easily differentiated with your corneal light reflex test. You can see that it is central. And a simple pinch test can also show, you can explain to the parents that that's actually not a true strabismus. A Hirschberg corneal light reflex will help in detecting the amount of strabismus that is present in a child who is not cooperative. So in this case, you can see the reflex that is falling at the pupillary area. So you can approximately tell that there is around 30% diopters of deviation of ESO or EXO in each case. A modified Kimsky test will help in quantifying the deviation. Remember to always start your examination with sensory evaluation. And why this is so? Because you need to do this examination before you dissociate the eye. Always start the test for stereopsis, and you know that there are different tests for stereopsis. What we usually follow here is the Titmus fly test. So as you can see here, the child is asked to wear the Polaroid glasses and asked to catch the wings of the fly. And you can see that if the child is having a 3 division, he catches above the book, and you have these grades of animals and these rings which are popping out. So you can ask the child to press that, whichever is popping out. So by this you can tell the stereo acuity. TNO is another test wherein you ask the child, you can see, to wear the red-green glasses and check for the stereopsis. If the child refuses to wear glasses, definitely you have tests called Lang test, which doesn't require any glasses, and the children are very cooperative to do this. Wirth-Fodor test is one test which helps in detecting if there is a fusion or not. The child is made to wear red-green glasses. It helps in detecting if there is a normal vision or there is a normal fusion or there is suppression. But remember that you have to always do a near Wirth-Fodor test as well, because cases like microtropia, they tend to suppress for distance, but they may fuse for near. The a disadvantage of Wirth-Fodor test is that eyes are easily dissociated in this condition. So a patient who is having a functionally useful binocular vision may actually show a suppression when you do a Wirth-Fodor test. And another disadvantage of this Wirth-Fodor test is presence or absence of bifoveal fusion, or there may be a bifoveal fusion even in cases of an abnormal retinal correspondence. Begolini stride glasses is less dissociative when compared to the Wirth-Fodor test. So it is more testing the reality, what you do. So this is more preferred than you do a Wirth-Fodor test. So as you can see the striations which you saw on the glasses, and corresponding to that you can see a cross, or if there is a suppression you will just see a single line. Then you go on for motor evaluation. So in motor evaluation, the cover test. This is the most important test to detect the amount of tropia. So as you can see here, when you cover the right eye in this child, the left eye is taking up fixation. When you remove the cover, the left eye goes back to its original position, which means that the child prefers the right eye and the dominant eye is the right eye. In case of a uncovered test, it helps in detecting a phoria component. So you can see that when you cover, you don't see the movement in the other eye, but when you remove the cover, you see under the cover of that eye, and that amount will show the phoria component. So the uncovered test basically measures the phoria. And then you have the alternate cover test, which measures both phoria and tropia. Remember to do a cover test for near as well. And this is the prism cover test, which helps in measuring the amount of deviation, as in here I have placed a basin prism. And always look at the extraocular movements. Ma'am will, the next speaker will all be talking about the extraocular movements. So definitely you have to look at the extraocular movements, which has been, which muscles are being acted. And remember one thing, that when you are checking for a child, always correct the posture, because that is when the deviation will manifest. And then you go on to look for the movements and see if there is a limitation of the extraocular movements. So sometimes if you don't do the extraocular movement examination, you miss out these conditions. And more than the pediatric refraction, which Ramya has already told about the importance of it, but remember that there are some deviations which can merely be corrected with glasses. So if you identify it, you can give a full strabismic correction for the child. Bruckner's test, she has already told about it, and this helps in detecting strabismus, especially in the strabismic eye, the images will be clear. And anterior and posterior segment examination is definitely mandatory in all cases of strabismus, not to miss out anything else. And this is the consensus which has been given when to examine the child. At least by 3 years, the child has to be examined once. Thank you, one and all.
Thank you, Dr. Soumya. That was an extensive talk on strabismus evaluation. Next, we have Dr. Laila Madam talking on importance of extraocular movements in children. Over to you, Madam.
Morning. So now we come to the importance of looking at the extraocular movements. So examination of extraocular movements is important in a child who presents with squinting or an abnormal head posture. And in any child where they suspect an occasional squinting or occasional head posture, you have to look at the extraocular movements. It's not always possible to make them look in the extreme positions, especially vertical gaze positions in an infant. But observation as and when the child is brought in and looking during history taking and the doll's head movement usually help. And just to brush through the extraocular muscles, we have 6 muscles. We know superior oblique and lateral rectus are supplied by the single nerves, and third nerve supplies all the rest of the 4 muscles. Though there are 9 gaze positions, 6 diagnostic gaze positions test these specific muscles in their discrete action. Like we know superior rectus is up and out, inferior rectus down and out, and inferior oblique up and in, superior oblique down and in, and so on. So versions are binocular synchronous symmetrical movements of the eyes in the same direction, and ductions are uniocular movements examined when versions are not full, and vergence is synchronous movement in to the opposite side. In the opposite directions, inward is convergence and outward is divergence, and we can document them in a scale of -4 to +4 with underaction and overaction in an H pattern. And grading of overaction and underaction of inferior oblique and superior oblique when there is an upshoot, or what we call over elevation in adduction and over depression in adduction, and showing elevation and depression, there is a marked difference of showing B pattern or A pattern. This is important. And as already pointed out by Dr. Soumya, observe for an abnormal head posture. You can see this child showing, is there a pointer? That the child has a very subtle left head tilt, which when corrected only shows the hypertropia. You can see here. You can see there is hardly any hypertropia here, but when corrected, we can see the hypertropia. So also the chin up posture, which when corrected, and there is a face turn to the right, you can see the eye goes out. There is a Brown syndrome left-sided, and this is a DRS child with the mild head face turn to the right. So versions are binocular pursuit movements. They are following movements, synchronous. Look for any asymmetry. You can, before using a cover test, you can just see the movements, and this is doing in subtle movement abnormalities. You have to do a cover test in all these gaze positions, diagnostic gaze positions, and document them. And the speed of movement is also important. This is versions. This child is actually looking at the, this is levo version. but the left eye is not moving because he has a cross fixation. As soon as the right eye is covered, this OK and drum, he is looking with the left eye. So now you know that duction is full. So this is another child with a, she has dextroversion is full, but levoversion is not. And you ask the parent to cover the left eye because sometimes they may not allow us to touch the face. So the father is covering the left eye, and then you can see the adduction is still not full. And you can also note that there is if there is a pseudotosis or not when covering the other eye. That is another useful information you get from cover test. This is vergence, convergence and divergence can be tested by moving a fixating object. The saccades also, the speed of movement also has to be looked at. This is there is an upshoot, sudden abrupt stopping of the movement. There is a normal saccadic velocity is there, whereas this patient has a slow movement, which you can see a floating movement or floating saccade, as you can see. So this is a child as this is very easy to miss in a very young child because they keep the chin up and try not to look at not to elevate. Duction test that it is moving fully, but in restrictive strabismus there will be no movement. And this is a force generation test where you look at the generation of force generated by the medial rectus, whether to tackle the medial rectus at all. In a child, the force duction test may not be possible in office. You may have to do it under anesthesia when you plan for surgery. And this is a positive force duction test. In Brown syndrome, you can see this eye is moving up and in very freely. And you go to the other side, left side, there is no, there is marked restriction of movement up and in. Oh. So this is superior oblique traction test. When you suspect superior oblique palsy, you want to know the laxity of superior oblique. In V pattern, we must know whether there is an over elevation in adduction to see which muscle has to be tackled. This is a V pattern without inferior oblique overaction, where you will not tackle the inferior oblique, but displacement will be done. Here you can see downshoot in adduction in both eyes, and an A pattern. There is more than 45 degree when he is looking down. A pattern corrected after superior oblique posterior tenectomy is done. To summarize, testing extraocular muscles in children is an art and needs patience and examining again when necessary. And extreme positions may be checked by doll's head movement and specific tests in individual cases. Not all tests need to be done in every case. Thank you.
Thank you, madam. That was a wonderful talk on extraocular movements. I think the single most important test in a child with strabismus is the extraocular movements. Thank you, madam. So now we'll come to the last talk, relevance of posterior segment evaluation in children. Over to you, madam.
Yeah. Thank you, Ramya and KSOS for this opportunity. So, what is the relevance of posterior segment evaluation in children? So just like in any case, it is very relevant because the prognosis of the child's condition totally depends on the posterior segment health. So, but it's a very challenging task in children because children don't complain. And so you have to have a high index of suspicion about the posterior segment abnormality and do the necessary investigations. There may be diverse pathologies and there is a technical difficulty in examining the child. So you may even have to do an examination under anesthesia. So, and when should you do a detailed posterior segment evaluation? Most of the time, we're just able to get a glimpse of the posterior pole, disc and macula, and that's it. In children, you can't do a detailed peripheral examination. Ideally, you should do in all cases, but in certain cases, you must do a detailed examination. And which are those? Definitely in premature babies, when you're looking at ROP. I'm not going into detail because I think there is an entire session on ROP in KSOS, but prematurity does remain the first condition. Then any child with an unexplained vision loss, you must do a detailed examination. Any child with poor vision, which you cannot explain, with nystagmus, with sensory strabismus, trauma, definitely you should do a dilated detailed examination, pre and post surgery, especially a cataract surgery patient. When you're suspecting ocular tumors, suspected syndromes, which are referred by a pediatrician or a neurologist to you to look at the fundus and give them inputs, and systemic conditions. So these would be a bunch of conditions in which you would definitely have to sit down and do a detailed examination. How to do a posterior segment evaluation? Just like in adults, but it's again different because most of the time in a regular OPD, you're just able to do an indirect ophthalmoscopy with force. You have to ask the sister, as Ramya showed, put the child down and do, or if the child is cooperative, you can do an indirect along with the slit lamp biomicroscopy by making them sit, kneel, or stand on the slit lamp and get a good look at the macula. Fundus photography definitely helps, especially with the advent of optos. You actually get an entire peripheral view of the retina and you may pick up lesions which you have missed. In children in which there is hazy media or not a good view of the fundus, definitely you must do an ultrasonography B scan to document the posterior segment. And with the help of OCT, we can actually know more about the pathology. And in suspected cases of unexplained vision losses, definitely you have the electrophysiological tests of electroretinogram and VEP to your aid. So let's look at some illustrative case scenarios. So this was a case of an 8-year-old boy who was detected to have accidental vision loss in the left eye. His visual acuity in the right eye was 6/12 and left eye was counting fingers 2 meters. He had compound hypermetropic astigmatism. So was it amblyopia? On asking repeatedly, they said there is family history of poor vision in the paternal grandfather and in the uncle. So this is his fundus picture. I don't know if you can see. The right eye essentially looks normal, but in the left eye, if you see, there is a linear area of subretinal fibrosis, which you may actually miss if you don't do an indirect ophthalmoscopy and a 90D examination. And there are some foveal changes. The foveal reflex was not good, and peripheral examination showed some pigmentary changes. So that's when we got this optos. So you can see nicely the optos is showing beautifully what he's having, and he was cooperative enough for an OCT, and you're seeing schitic changes in the fovea. So before labeling any child as amblyopia, please make sure that he's not having a pathology, and he turned out to have a juvenile X-linked retinoschisis. So it is important that you document this, and in cases which you cannot explain, at least refer them if you don't have the necessary investigations at your place. So this is a typical bicycle spoke wheel maculopathy, which you can see on 90D, but otherwise OCT will pick it up. So this was another case of a 5-year-old girl brought again with squint, left convergent squint. The eye was a little smaller, and she had a best corrected visual acuity of 618 N8 with a -5 sphere and a -2.5 cylinder at 120 degree. So again, very important to look into the fundus before you say it is just refractive error causing amblyopia. See, what you see is she has a large optic nerve head coloboma in the left eye. Yes, we will definitely give glasses and patching to this child, but you have to give a guarded prognosis to the parents that the vision will never be as good as the right eye. So that is the importance of posterior segment evaluation. So this was another case which was referred as traumatic optic neuropathy, defective vision after trauma. Left eye was good, right eye was 618, N12. No RAPD. Very important, you yourself check the pupil and the color vision. And fundus was looking normal, but the right eye, the foveal reflex was dull. We got an OCT done, retinal nerve fiber layer was good. Is it an with the no RAPD, I was sure it was not traumatic optic neuropathy. We looked into the macula with OCT, and what you see is a scar. So this is a traumatic maculopathy. Again, you have to explain to the parents, yes, there is a problem with the trauma, and with the pictures, you can actually tell them what has gone wrong in this patient. So posterior segment evaluation in cataract surgery patients is a must because it is important not just for the prognosis, but you don't get any intraoperative surprises. So all the tests that I've described can be used, but a basic B scan definitely should be done in suspicious cases. So this was a 1-year-old girl with intermittent exotropia of the left eye. She had a central cataract. So she was not cooperative for slit lamp examination. This is her intraoperative picture. But I put her down and I saw that the fundus I could see, but there was a suspicious stalk running from the optic nerve her to the posterior lens capsule. So my doubt was, is it a persistent fetal vasculature? But when we did a B scan, it was absolutely normal. See, no stalk. Axial length was good, around more than 20. So everybody said this is not PFV. Anyway, I kept the suspicion in mind, and this is what happened intraoperatively. You can see post-lens aspiration, there was a plaque on the posterior lens capsule. And can you see the stalk? This stalk running from the optic nerve to the posterior lens capsule. Sometimes it will bleed. When you do the posterior rexus, it will bleed and you can produce massive vitreous hemorrhage, and you may have to call the posterior segment surgeon. But because I had the suspicion in mind, I was able to cauterize it with the endocautery and avoid the bleed. So that is the importance of pre-op examination. So this was a case of a mild form of a combined PHPV. So Dr. Coker has described this technique in which he uses a retinal lens after lens aspiration, fills the AC with an viscoelastic, and uses an endo-illuminator to illuminate and look at the fundus. So, but we can anyway do an indirect ophthalmoscopy in a sterile manner after the lens aspiration to look at the fundus if you have not seen it before. Another case of a myelinated nerve fiber, again will be referred to you as amblyopia, but look at the extent of the myelinated fiber. So there is a triad of severe myelinated nerve fiber, high myopia, and amblyopia. So this is Stratsmas syndrome, and it is not going to improve. It's a case of refractory amblyopia. There is a structural problem, thickening of the nerve fiber layer at the disc as well as in the macula, and it's not going to improve. So this is the importance of explaining the prognosis to the parent. So I think the time is over. So sometimes in systemic conditions like tuberous sclerosis, you may be asked to look at it, and we was able to pick up the hematomas with the help of the OCT, and we published it. And this is the last case referred again by pediatrician to rule out a retinopathy because he was suspecting some condition, and we were able to document with ERG, flat ERG's retinal dystrophy. It turned out to have this eye of the tiger appearance on MRI, and it was pantothenate kinase deficiency. Again, juvenile glaucomas can be picked up. Can I take 1 minute? There is time, yeah. So this was referred as a neurological cause, but if we look carefully, she had large cups with hardly any neuroretinal rim. Child was tripping and falling off. And RNFL was very thin. She had borderline high IOPs. This was a case of juvenile glaucoma. She underwent trab with trab and did very well. And optic neuritis, again, be careful before you label it as optic neuritis. Do a B scan and an OCT FAF to make sure that it is not optic nerve hydrusen, which was the case here, and we could tell the parents. So again, post-retinoblastoma treatment, you may be asked to follow up. Again, you have to do a detailed fundus examination, dilate it. Sometimes you have to do an EUA because you shouldn't want to miss any new lesions. You can see the regress retinoblastoma, cottage cheese appearance here. So I think this summarizes the various cases in which you would do, and thank you, Ramya, for this opportunity.
Thank you, madam. All those cases with the beautiful fundus pictures, really nice. Okay, now the session is open to questions.
Wonderful talk, Dr. Neena. Uh, Actually, the importance of branding them as amblyopia. I've had children, 3 to 4 years, vision not improving beyond 618 in spite of having good refractive correction. And then subtle changes at the macula. Sometimes wheel pattern is not very much seen. Juvenile retinoschisis is not very uncommon. And intermittent exotropia and myopic astigmatism, compound myopic astigmatism is very commonly seen, and an OCT showed schisis. It's very, very common.
Yeah, madam is asking till what time we can do patching. So actually there is no age bar as such. Even in adults also we have seen improvement. If the vision is not improving after your 6 months or 1 year of patching, then there is no point in patching. But you can try. Anyways, you can try. Yeah. You can definitely give it.
The amblyopia treatment study said that if the child had never ever had a patching before and newly detected, you must definitely give a trial. And myopes will definitely improve. Hypermetropes not going to improve so much. So definitely you can try for 6 months to 1 year if they are motivated.
I would like to ask the panelists that what type of amblyopia you have seen most resistant to occlusion. In my cases, I have seen with anisometropic amblyopia rather than strabismic. How do you all? Yeah, hypermetropic and
Hypermetropic, anisometropia, and strabismic.
I think stimulus deprivation amblyopia is the most resistant for occlusion. Any cataract, dense cataract which has come, or strabismus which has come in the early age, they are like very difficult to think. But you have to be persistent in every visit. Keep telling that you have to do patching, and then the parents, when they are more motivated, then it is easier to handle children at an earlier age than at a later age, because you can always tell that ഒരു വയസ്സുള്ള കുട്ടി കോപ്പറേറ്റ് ചെയ്യുന്ന പോലെ ആയിരിക്കില്ല 4 വയസ്സുള്ള കുട്ടി കോപ്പറേറ്റ് ചെയ്യുന്നത്. നിങ്ങൾക്ക് ഇനി ബുദ്ധിമുട്ടായിരിക്കും at 4 years if you ask them to do it. So better start the early. You get better improvement when you start it early. That's what
Definitely, age is the main factor. If you delay patching, within we have seen essential esotropia. If there is a dominance of one eye, within 1 month they switch. If you patch, if you see early, within 6 months, that is what we see usually.
And comparatively, somehow, anisometropic amblyopia do better than strabismic and sensory.
Yes, just one question to the panel. In iso and ametropic amblyopia, how fast would you start patching, and is there any role of patching at all at any stage? Some people give alternate patching.
So like what we were told is that there is no role of patching in
If
isometric
binocularity
ambliopia.
is compromised, then
Yeah.
maybe they can.
What I do is that we give the optical correction first and look at the age of the child. So if the child is only 5 years, 6, 9 is good. But if it's a 12-year-old child, then you need to rule out other things.
there is a recent study now where they have told that patching does find some improvement. even
Okay,
in
now
isometric.
we'll come to the end of the session. I would like to invite, call Dr. Radha Devi madam for distributing the certificates to the speakers.